Good afternoon. Welcome to the 2026 McDonald Center for Nutrition Education and Research webinar series for health professionals. My name is Lisa Dewald, and I am the Associate Director for the Villanova University's Fitzpatrick College of Nursing's McDonald Center for Nutrition Education and Research. There are nearly 500 health professionals registered for this webinar today, and we're so glad that you are taking the time to spend with us today. According to the World Health Organization, cardiovascular disease continues to be a major cause of disability and mortality globally, resulting in an estimated 17.9 million deaths annually, most from heart attack or stroke, and 1/3 occurring in adults under the age of 70. Treatment with omega-3 fatty acids has been studied extensively as a therapeutic option, but benefits and risks require careful consideration. During today's program, we'll take a walk through published research on omega-3s over the years, including randomized controlled trials and a major meta-analysis, and discuss omega-3 fatty acid use in preventing major cardiac events, as well as potential risks and practical implications for guiding treatment decisions. In a few minutes, I'll introduce our speaker for today, Dr. Carl Lavie, an expert in the study of omega-3s and cardiovascular health. Slides for today's webinar are posted on the Villanova University Fitzpatrick College of Nursing's McDonald Center for Nutrition Education and Research website. Simply go to the website listed on your screen, and from the right menu, look for webinars, and then go to today's webinars to access the slides. Villanova University M. Louise Fitzpatrick College of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. This activity awards 1 contact hour for nursing professionals. This activity also awards 1 CPEU in accordance with the Commission on Dietetic Registration's CPEU Prior Approval Program. Suggested CDR performance indicators are listed on the screen. And just a reminder, you must attend the whole program to receive CE credit. No doubt you'll have questions throughout today's presentation. Please feel free to send in your questions through the Q&A box, and Dr. Lavie will answer as many as time permits following the webinar. Dr. Lavie's disclosures are listed on the slide. He'll also mention them when he begins his presentation. The nurse planner will monitor the program for any evidence of commercial bias. Planners will review participant feedback to evaluate for any real or perceived commercial bias in any activity. And now I have the pleasure of introducing today's speaker. Dr. Lavie attended medical school at Louisiana State University Medical Center in New Orleans, completed his internal medicine training at Ochsner and cardiology at the Mayo Clinic. He is currently professor of medicine and medical director of cardiac rehabilitation and prevention, and director of the exercise laboratories at the John Ochsner Heart and Vascular Institute, Ochsner Clinical School, the University of Queensland School of Medicine in New Orleans. He has authored over 1,800 medical publications, number 1319 on PubMed, with an H-index of 162, and has authored 2 cardiology textbooks. Dr. Lavie also serves on over 40 editorial boards, including previously the Journal of the American College of Cardiology and JACC Heart Failure, and currently Heart, and is an associate editor and cardiovascular section editor of the Mayo Clinic Proceedings. He was also editor-in-chief of Progress in Cardiovascular Disease for 12 years and is the author of the book, The Obesity Paradox. And so we're thrilled to welcome Dr. Lavie to our Villanova webinar series and invite him to go ahead and share his screen. I'm going to stop sharing mine, and we will go ahead and get started. Welcome, Dr. Lavie. Thank you so much for being here.
Let me just make sure that, and can you all see my slides now?
It's coming.
Okay.
Let's see. There we go.
Okay.
We're good.
All right, great. Thanks, Lisa, for the introduction. And It's a pleasure to be here this morning. And this is one of my favorite topics. I probably give more grand rounds on exercise and cardiac rehab and obesity and lipids, but this is certainly one of my favorite topics. As mentioned, I have a couple of disclosures. I think they're fairly minor, but I have been a consultant and speak of GOED and DSM in general on omega-3, but not on specific products. In the past, I spoke for Amarin, but that's been many, many years ago. We're going to have several objectives today. We'd like to really go over the specific health outcomes related to the main components of omega-3, which is EPA, icosapentaenoic acid, and DHA, docosahexaenoic acid, for omega-3 intake. We'd like to identify resources for getting omega-3 levels potentially checked, and why this could be important information. It's honestly not done very much clinically, but occasionally it could motivate patients. And would like to provide accurate information for patients about the potential benefits and risk of increasing their omega-3 levels. Now, actually, my very first paper on omega-3 was when I was a medical fellow at the Mayo Clinic, but the paper we actually wrote was in 1986, 1987, when I was a resident, medical resident here at Ochsner. This is a very major paper 15 years ago in our leading cardiology journal, JACC, at the time going over in 2009, the major evidence at that time on omega-3, and the evidence certainly has increased since that time. This is a pretty, I think, interesting quote that I saw in the New England Journal of Medicine right at about the time I was writing my first omega-3 paper. It was by Rogans in 1987, New England Journal. It said, "Fish oil is a whale of a story that, not surprisingly, gets bigger with every telling." Now, way in the past, our foragers used to have very high cholesterol intakes. They had a lot of fat in their diet, but the saturated fat was not so high, and they had a lot of omega-3 in the diet. Whereas in more modern times, the cholesterol intake is lower, the fat intake is lower. Saturated fats, on the other hand, are considerably higher, but the omega-3 intake has gone down dramatically. But there are places in the world that have higher omega-3s and seem to have very good life expectancy. Now, I'm going to go over really a couple of these trials, but there's been some really major ones that they're not super new at this point. The DART trial, the GISSI Prevenzione, the GELIS. I'm going to go over in a little detail the GISSI and the GELIS trials. The GISSI Prevenzione trial was done in Italy in the late 1990s. Of post-myocardial infarction patients, 11,324, who were randomized to a brand name of omega-3. It was at the time it was called Omacor. The time this slide was made, they changed the name to Lovaza, and now it's a prescription omega-3 that basically contains about 850 milligrams of combined EPA plus DHA versus control, with the 3.5-year follow-up. They also had a vitamin E on, but I'm not going to discuss the vitamin E data for this. During this trial, during just the first year of this trial, those who were randomized to the omega-3 had a 41% reduction in all-cause mortality, a 53% reduction at 120 days, and a 47% reduction at a year in sudden cardiac death. Coronary heart disease mortality fell by 38% by 240 days and by 28% at the end of 1 year. And cardiovascular disease mortality fell by 36% at 240 days and by 30% at the end of 1 year. Pretty dramatic findings. Now, you got to realize that this trial was done before the age where myocardial infarction patients were being treated with dual antiplatelet therapy, very strong blood thinners, with high-dose statins, with commonly getting revascularized with stents and other procedures to open up their arteries. So the patients were being less treated otherwise, and so it's generally easier to be able to show event reduction. And then if you start doing other very vigorous treatments, it's harder for the same therapy to produce the same dramatic results. And we'll discuss, for that reason, some more recent data that also supports omega-3. Another very big trial that was done many years ago was the JELIS trial. And this was done in 18,645 patients. About 15,000 of them were primary prevention, means they didn't have evidence of cardiovascular disease, and 3,600 was secondary prevention, meaning that they did have evidence of cardiovascular disease at baseline. This trial was statin therapy alone, but the statin was usually very low doses of a mild statin called pravastatin that is not nearly as strong as the statins that we typically more use today, high doses of atorvastatin and rosuvastatin. So statin alone or statin plus EPA, eicosapentaenoic acid, 1,800 milligrams per day, and generally this was given by 300 milligram capsules, so they took 6 capsules of EPA. And in this trial, EPA therapy was associated with a 19% reduction in major cardiac vascular events. It didn't reduce sudden cardiac death, though, and this shows the Kaplan-Meier curves showing that, again, at the end of the trial, there was a 19% reduction in the primary endpoint. But if you look at the entire cohort, again, it was a statistically significant 19% reduction. The primary prevention cohort had almost the exact same percent reduction in events, 18%, but it was not statistically significant because if you notice that the event rate was considerably less. It was 6 times less in the primary prevention patients than it was in the secondary prevention patients, and the secondary prevention patients had a statistically significant benefit. Also in this trial, it was shown that those who reached the highest levels of EPA had the best clinical event reduction. So again, a pretty significant overall trial with EPA alone. We're going to talk a lot about the combination of EPA and DHA, but particularly important for many of you who are dietitians, what about ALA, alpha-linolenic acid? Alpha-linolenic acid is found in flaxseed, canola, olive oil, walnuts, other tree nuts, and in trace amounts in green leafy vegetables. Humans typically convert less than 5% of the ALA to EPA, eicosapentaenoic acid, and much less to DHA. And so EPA and DHA is really what one wants to have to give the best prevention. Some studies with ALA have been positive, whereas many were negative. And so certainly the overall evidence is much less for ALA than it is for EPA or for EPA-DHA combinations. A major meta-analysis that I was very fortunate to be able to write the editorial for, as being at the time associate editor, which I still am at the Mayo Clinic Proceedings, a major meta-analysis by Alexander in the 2017 Mayo Clinic Proceedings. The meta-analysis used 18 randomized trials and 17 prospective cohort studies and basically showed a significant 18% reduction in coronary heart disease in the prospective cohort studies and pretty significant overall reductions in other groups, particularly in those who had elevated blood triglycerides or elevated low density cholesterol, LDL cholesterol values. And this paper got a lot of attention in the media, and I was fortunate to be one of the co-authors on the editorial talking about omega-3 fatty acids, the tide turns for a fish story. Another big meta-analysis around the same time was by Maki and colleagues in the Journal of Clinical Lipidology. This study was 14 randomized trials in close to 72,000 participants, and they were specifically trying to evaluate cardiac death, overall cardiovascular disease death. And they found that in this meta-analysis, not a huge effect, but overall about an 8% reduction in cardiovascular disease mortality in those who were randomized to omega-3. And there were about 13 to 16% reductions in cardiac mortality in those who were a little bit higher risk due to having higher LDL cholesterol, triglycerides, or less use of statins. And again, to point out, since statins itself reduce risk so much that a lot of times when you reduce risk with something else, it's harder for your own therapy. So the patients who weren't taking statins or were using lower doses of statins had even more benefits from omega-3 therapy. There was a very, very major Cochrane analysis, though, that didn't find a significant effect of omega-3. There was a paper that got a lot of attention, actually, from Rizos and colleagues in JAMA, really, Journal of American Medical Association. Many people consider it the top 2 or 3 medical journals in the world. They actually showed in the paper that there was some significant benefits of omega-3 by most people's estimation. And most of the times, most research studies place the p-value for statistical significance at p less than 0.05, meaning that there'd be a 95% chance that these results are legitimate and not just by chance. But this paper set the p-value at 0.01, and so it was a much more vigorous, and so many of the findings would have been statistically significant by usual standards, but were not, and they basically discounted sometimes even 15% clinical event reductions with p-values that were well less than 0.05. And again, the Mackey paper that we just went over also had a significant effect. So a couple of years ago, in 2018, in November of 2018, at our American Heart Association meetings, there were 3 big papers, Reduce It, Vital, and a third paper that all were done with omega-3s, all presented at the same meeting and published that day in major journals. We reviewed all of these 3 papers in a major review article in the Mayo Clinic Proceedings the following year that also got a lot of publicity. But the 3 big papers that came out that day in November 2018 were the Reduce It trial, which is probably the strongest of all recent lipid trials when added to statin therapies. The Vital trial was reported as negative that day, but had some important CHD findings. And the Ascend trial was also reported as negative in a diabetic cohort, but also had some important vascular disease findings. So first of all, the Reduce It trial was about 8,500 patients, all at high risk. All were being treated vigorously, mostly with high doses of statins. And they were randomized to EPA alone, eicosapentaenoic acid, as 2 capsules twice daily to give about 3,500 milligrams per day of EPA. Now, you can get EPA and DHA from dietary sources, but I don't know of an easy way one can get high doses of pure EPA now from just diet. So this would have to be in a capsule. And remember, that's what was used in the Jellish trial. The Jellish trial used 300 milligram capsules, and this was using 1 gram capsules that added up to about 3,500 milligrams per day of EPA versus placebo. And you can see by this slide, big clinical event reduction. The primary composite endpoint was reduced by 25%. Cardiovascular death, a non-fatal MI, was reduced by 25%. Fatal, a non-fatal heart attack, reduced by 31%. Big falls and stroke by 28%. And death from any cause was not statistically significant. But when I was given an omega-3 conference right before COVID hit in Barcelona in February of 2020, a paper came out in circulation of the U.S. cohort in this trial, and the U.S. cohort actually had a significant 30% mortality reduction with the EPA therapy. Now, on that same day in November 2018, the Vital was presented of about 26,000 primary prevention patients who were randomized to basically the prescription drug Omicor, later called Lavie, now it's a generic omega-3 prescription agent. And when it was presented that day in November 2018, it was presented as a negative study because the major cardiovascular disease events were not statistically significantly reduced. But if you look at some of the subgroups, some of the things had pretty nice reductions. Total MI, need for percutaneous intervention, meaning a stent, total coronary heart disease events, and death from MI were all significantly reduced. Now, this was a pretty healthy population too, because the median fish intake of this population was about 2 fish meals per week. I would estimate in the United States as a whole, the average person probably has less than a half of fish meal per week. So this group was taking in way more fish. They did show in another subgroup analysis that the group who took less than the median fish intake had statistically significant reductions in the major primary endpoint and all of the sub endpoints. So the patients who had less baseline fish intake got even more benefit. And then the third big trial that was published that day, the ASCEND trial of 15,000 diabetics, again reported as negative, but still, if you look at vascular disease death, was reduced by 18%. The other endpoints were all reduced, but not quite statistically significant. So again, I think many people would think that reducing vascular disease death would be an important endpoint. So we decided to take these 3 big trials and do a meta-analysis, adding them to the previous data. And we ended up publishing this data in the Mayo Clinic proceedings, and I presented this data in Barcelona at a big omega-3 conference in February of 2020. We basically updated the April 2017 paper from the Cochrane analysis and also assessed dosage effects. We only included randomized controlled trials of the dietary supplements, not just dietary advice. So we didn't use any trials that just gave advice for diets. They all were basically using supplements. We assessed the major events: myocardial infarction, coronary heart disease events, fatal heart attack, coronary heart disease death, and cardiovascular disease events in 40 studies of 135,000 participants. Again, we excluded the DART studies, which were just dietary advice. And I know, again, not to discount dietary advice, it's just a little bit hard to quantitate how much of this, unless you were measuring the omega-3 levels in the blood. The dose in these trials varied from 400 milligrams per day of EPA-DHA in combination to 5,500 milligrams per day. The dose was less than 800 milligrams per day in 5 studies of over 8,000. It was between 8 and 1,200 milligrams per day in 10 studies of 95,000, and over 1,200 milligrams per day in 25 studies with an N of 32,000. The mean dose was about 1,200 milligrams per day of combined EPA-DHA. And this was the major endpoint. During the follow-up, fatal heart attack was reduced by 35%. Total heart attacks were reduced by 13%. Coronary heart disease events were reduced by 10%, right at close to 10%, and 9% for coronary heart disease mortality, and 5% for total cardiovascular disease events. That was not quite statistically significant. The p-value was right at 0.05. So again, pretty nice clinical event reduction. The number needed to treat was certainly higher to reduce an event than we have in most of our cardiovascular trials, but you got to realize most of our cardiovascular trials are using expensive agents. We're using devices that could cost $10,000, $20,000, using prescription medicines that sometimes are costing $5,000 per year. This is a very simple therapy, omega-3, again, producing 35% reduction in fatal MI, 13% reduction in total MI, 10% in coronary heart disease events, 9% in fatal coronary heart disease, and 5% in total cardiovascular disease events. Then the dosage mattered too. We assessed the total dose of EPA-DHA on major clinical events, and generally higher doses were associated with greater reduction in cardiovascular outcomes. Each additional 1 gram per day of combined EPA-DHA led to risk reductions of about 6% for cardiovascular disease events and about 9% for myocardial infarction or heart attack. There's also perception that the older omega-3 studies, like the GISI Prevenzione that I went over at the very beginning, were more positive than the more recent studies. And certainly that would make sense because medical and interventional treatments are now much more effective. And so the more you use other therapies, it's harder to show additional benefits of something that was previously shown to be beneficial. But again, the 3 big trials done November 2018, the Reduce, the Vitality, Ascend, all had some positive results. And we actually statistically did not find any significant effect of the year of publication on the omega-3 benefits on cardiovascular disease outcome. There's also debate, and many people have strong feelings about this, that of whether EPA, icosapentaenoic acid, is more important than the combination of icosapentaenoic acid and docosahexaenoic acid. And of course, in all of our fish intake, dietary fish, and almost all of the supplements are going to have combined EPA, DHA, with some specialized formulations that have just pure EPA. Again, EPA alone was very positive in high doses in the Reduce It trial and in moderate doses in the GELIS trial. So we assessed the EPA doses versus the combined EPA DHA doses on cardiovascular outcomes, at least statistically, and we did not determine any significant advantage statistically of total EPA versus the total EPA DHA doses on major cardiovascular outcomes. Another big meta-analysis around the same time as ours was also published of close to 130,000 participants. They used many less trials, but all of their trials, they only used trials that had an N of over 1,000 and a dose of at least 840 milligrams and at least a 2-year follow-up. So they had 13 trials of close to 130,000 people, and they also showed benefits. 8% lower heart attacks, 8% lower coronary heart disease death, 5% lower total coronary heart disease, 7% lower total cardiovascular disease death, and 3% lower total cardiovascular disease events. All that was statistically significant. And they also found that the benefit was more with higher compared with lower doses, realizing that they didn't use any doses of less than 840 milligram per day of combined EPA DHA. Now, after these were published, though, there was still a couple of more trials that came out. One was the Strength trial that used a very unique, never used before formulation of omega-3 in patients with high risk that had some similarities to Reduce It trial, except they used, again, a very unique preparation that's never been used before and never been used since, to my knowledge, and had negative findings. And there was a big trial in elderly post-myocardial infarction that also had negative findings, meaning no adverse effects, but no beneficial effects. So we were asked then by the editorialist of our paper in the 2021 Mayo Clinic Proceedings to consider adding these trials to our meta-analysis to see if it's still significant. So we added the Strength and the OMI. We now went from 40 trials and 135,000 to now 42 trials and close to 150,000 people. And only cardiovascular disease events and coronary heart disease events changed. The cardiovascular disease events were now reduced by 4% instead of 5%. The coronary heart disease events were reduced by 9% instead of 10%. And each 1 gram dose of combined EPA DHA reduced MI by an additional 9%. So after adding Strength and OMI, we still showed fatal MI was reduced by 35%. Total MI was reduced by 13%. Both coronary heart disease events and coronary heart disease mortality were reduced by 9%. There was a borderline 4% reduction in cardiovascular disease events. So we felt that still very significant and strong effects of benefit of omega-3 was seen following the Strength trial. And we published this additional analysis as a research letter later that same year in 2021 Mayo Clinic proceedings, and slide shows the main summary of our findings. Now, heart failure is probably becoming the leading cardiovascular disease, along with atrial fibrillation, honestly. And so the question is, what is the evidence for omega-3 right now in heart failure? The cardiovascular health study done 2 decades ago was a population-based study of 5,000 men and women and were followed for over 12 years. And they showed that the consumption of broiled or baked fish was associated with lower incidence of congestive heart failure. And you can see here that having 3 fish meals per week, very much lower event rate than having less than 1 fish meal per month in this population, published by Mozafarian in our major cardiology journal 2 decades ago. The atherosclerosis risk and community study had 3,500 patients followed for 14 years. They showed an inverse relationship between the intake of polyunsaturated fatty acids and the incidence of heart failure in women, but not in the men in this study. And a Japanese epidemiological study, of course, realizing that the Japanese were eating a lot more fish to begin with, but this was a very large prospective observational study in 60,000 men and women followed for 13 years. And they also showed an inverse association between omega-3 consumption and cardiovascular disease mortality, including heart failure mortality. So then there was a big randomized trial published in Lancet in 2008 of the GISSI heart failure trial. It was a trial of close to 7,000 patients where they were randomized to basically, again, that prescription omega-3, Omacor, later called Lovasa, and now it's available as a generic prescription that has a combined 850 milligrams of EPA and DHA. And realizing that one could theoretically get that much EPA and DHA from dietary sources, you'd have to eat a lot of fish, or you could certainly get that from over-the-counter supplements, get the combination of 850 of EPA DHA. And it was a 4-year follow-up of patients with heart failure. And they showed, again, significant but pretty small effects. They showed the unadjusted death rate was reduced by 7%. It wasn't statistically significant. But when they adjusted for pre-specified factors that they planned to adjust for before the trial started, they had a 9% mortality reduction with a p-value less than 0.05. And when they combined the probability of all-cause death or admission to the hospital for cardiovascular reasons, again, the unadjusted was reduced by 6% with a p-value not quite less than 0.05. But the adjusted, again, pre-specified adjustments, was an 8% reduction with a very strong p-value of close to 0.01. So again, significant effects, but not the 25-30% reductions that a lot of time the trialists are looking to have. And so although these benefits could, on first glance, seem modest, they still translated into 56 patients needed to be treated for 4 years to avoid 1 death or hospital cardiovascular admission. And importantly, this is just omega-3. This therapy is safe, inexpensive, well-tolerated, and combines with all the other things that we are doing in medical treatments and cardiovascular disease treatments. So the American Heart Association Scientific Advisory made a guideline in 2017 where they recommended omega-3 intake to be increased in patients with myocardial infarction and systolic heart failure. There's other heart failure patients. This is a big data bank from the United States, the MESA, of 6,500 participants, and they assessed heart failure over 13 years. There were 292 heart failure events. 128 of them were called heart failure with reduced ejection fraction, means the heart contractility was not squeezing good. And 110 were heart failure with preserved ejection fraction, which meant the heart was squeezing good, but was not relaxing normal. And 54 were heart failure with unknown ejection fraction. So they found that the higher EPA intake was associated with reduced heart failure. But honestly, the data with EPA and DHA was fairly similar. Again, they made a stronger case for the EPA, probably because of the enthusiasm for EPA from the Reduce-It trial just a year earlier. But the data with EPA and DHA, although statistically wasn't quite as strong, it was still very statistically significant as protective against heart failure in this population. We actually did a trial 2 decades ago of very severe heart failure. Patients who had class 3 to class 4 heart failure who had very, very severe symptoms, a very small trial of 14 patients. It was a double-blinded trial where we used very high dose omega-3, 8 grams per day versus placebo. And we showed in this trial that the patients on placebo, they had a 44% increase in what's called tumor necrosis factor, which is something bad, and no change in the interleukin-1, which is a very strong inflammatory factor. Whereas those who got the high dose omega-3 had a 59% reduction in their tumor necrosis factor, which would give them some benefits in heart failure, and a 39% decrease in interleukin-1, which would give them also some benefits against total cardiovascular disease, but also inflammation is very important in heart failure. We showed an inverse correlation between tumor necrosis factor production and changes in percent body fat as people who have advanced heart failure, if they're losing body fat, they mean they're usually losing muscle too, and that's not a good thing. And high dose omega-3 we thought might be beneficial for advanced heart failure, especially with cachexia and sarcopenia. And again, we showed a very strong relationship between the change in tumor necrosis factor with high dose omega-3 and the changes in percent body fat. And again, it might seem paradoxical, but we published papers years ago that in advanced heart failure, having low percent body fat was associated with much higher mortality. Now, certainly omega-3s are also used to treat triglycerides. Statins can reduce triglycerides. Omega-3 can reduce triglycerides. The combination reduces triglycerides even more so, particularly in patients with very high triglycerides. The patients who have very high triglycerides, and that's usually considered a triglyceride value over 500 milligram per deciliter. The normal triglyceride is probably less than 100, and we consider up to 150 to be in the normal range. 150 to 199 is borderline. Above 200 is elevated, and above 500 is very elevated. There's been studies with high doses of omega-3, like 3 to 4 grams per day, that are showing close to 50% reductions in triglycerides. And again, this can be easily added to statin therapy or other therapies for patients with high triglycerides. And we have some patients who have triglycerides in the many thousands, and this is quite dangerous for many reasons, particularly for the risk of pancreatitis. Now, there are ways that one could measure omega-3 in the blood. There's a thing called omega-3 index. It's a measure of the amount of EPA and DHA in red blood cells expressed as a percent the total fatty acids. For example, let's say there are 64 fatty acids in this model membrane, and 3 of which are EPA or DHA. So this would be a 3 over 64, 4.6% omega-3 index. In Japan, particularly years ago, they had very desirable levels, well over 8%. In the United States, we generally had undesirable levels, well under 4%. Now, Japan's probably falling. The United States is probably staying the same or maybe falling a little bit too in their total omega-3 blood levels. And basically the same is true for Europe. A big study in JAMA, now 3 decades ago, of assessed fish intake and the risk of cardiac arrest, and showed that those who had the highest intake of fish had big reductions in the risk of cardiac arrest. And when they also assessed these individuals for their omega-3 index, and they showed compared to those who had very low levels of omega-3, only 3%, those who got their levels to over 8% had nearly a 90% reduction in the risk of cardiac arrest. And then a few years later, they had a study in New England Journal of Medicine of U.S. physicians that showed almost the exact same thing, that those who had the highest blood levels of omega-3 had big reductions in the risk of sudden cardiac death. And so now a concern has been that now raised that omega-3 does a lot of good things, but it might slightly increase the risk of atrial fibrillation. And atrial fibrillation is becoming epidemic in the United States, probably because of obesity and probably also because of so much hypertension and so much alcohol in our society. A big meta-analysis by Gerson Circulation 5 years ago assessed the trials and basically showed that the trials of high doses of omega-3 at the bottom produced much bigger increases, 50% increases in atrial fibrillation, whereas the low dose trials were not significant for increasing atrial fibrillation individually, but when they did a meta-analysis of all of them, they slightly increased atrial fibrillation by about 12%. So again, the total was about a 25% increase in the AFib trials for atrial fibrillation, but it was only 12% in the low dose, a gram per day or less, and close to 50% in the higher dose, producing a total of about 25% increase in risk of atrial fibrillation. But just for example, the Reduce It trial increased atrial fibrillation by 35%. But one of the biggest things we care about in atrial fibrillation is stroke risk, and that trial showed a 30% reduction in stroke in the same patients that had an increase in atrial fibrillation. So the question is how important this is. But certainly there does appear to be a dose response of increasing the dose, increasing the risk of atrial fibrillation. Another meta-analysis basically showed about the same thing, 8 trials of 83,000 people that showed a 24% increase in AFib with omega-3, but only a 12% increase with the low dose of a gram or less, and a 51% increase with higher doses of omega-3. So this is my friend James O'Keefe did a major paper in stroke, though, a couple of years ago that showed that the blood levels of omega-3, as you got the blood levels into the higher levels, they had significant reductions in the risk of both total stroke and ischemic stroke. No change in hemorrhagic stroke, higher or lower, but total stroke and ischemic stroke were prevented by higher omega-3. So the bottom line, who really needs omega-3 supplements? I mean, some people would say everybody needs it. But I think patients with known atherosclerotic cardiovascular disease, a high atherosclerotic cardiovascular disease risk, hypercholesterolemic patients, hypertriglyceridemic patients, post-MI, those with systolic heart failure, are ones that particularly are in need of increasing the dietary or supplements for omega-3. Then who may not benefit from omega-3? Now, almost everybody could theoretically benefit from brain function and some other potential benefits of omega-3. But from a cardiovascular disease standpoint, maybe the patient who doesn't have any dyslipidemia, who doesn't have atherosclerotic cardiovascular disease, patients with very high exercise, without other strong reasons for needing omega-3, patients with bradycardia, because high-dose omega-3 can increase vagal tone. And so patients with high baseline vagal tone may be more predisposed to getting atrial fibrillation on higher doses of omega-3. And maybe these patients wouldn't have as much benefit. And again, it's hard to produce benefit in a very, very low-risk population. In a very low-risk population, it's hard for any therapy to produce additional benefits. So omega-3 dosing, the evidence for omega-3's clinical benefits are strong, especially at doses close to a gram of EPA-DHA per day. Dose does matter, and higher doses seem to produce greater cardiovascular benefits, although may slightly increase the AFib risk more. For higher risk patients, achieving doses of over a gram may be preferred, and certainly the GELIS and Reduce It doses of 2 to 4 grams per day may be ideal, realizing that these two trials were just pure EPA, not the combination, and these doses could be increasing the atrial fibrillation risk. Future directions, again, none of the major studies or meta-analyses, including our own, adequately assessed omega-3 in heart failure. Additional omega-3 studies are needed in both heart failure and both the reduced ejection fraction and preserved ejection fraction. Potentially 2 or 4 grams per day or even higher doses, as we showed in our very small study of advanced heart failure, could be beneficial in certain classes of heart failure. Certainly, additional studies are needed to determine the relative effects of EPA, DHA, and combinations in different disease states, and I think particularly with heart failure populations. So, in summary, prevention cardiovascular disease is realistic. Diet is a modifiable risk factor that can be influenced by the individual with clinician guidance, and certainly one can get guidance to use omega-3 supplements or to increase their fish intake to get good amounts in the diet. There's robust evidence for omega-3 benefits in cardiovascular health. Omega-3 intake and status is very low to low in most of the globe, including in the United States. Supplementation with omega-3s, therefore, a low cost and low toxicity therapy provides substantial benefits for individuals in society. And omega-3 intake via regular fish consumption and or supplements should be part of our prevention strategies, particularly at patients at moderate and high risk of cardiovascular diseases. And again, back to this quote from 2017, I'm sorry, from 1987, New England Journal of Medicine by Rogans, a fish oil is a whale of a story that, not surprisingly, seems to be getting bigger with every telling. Thank you very much, Lisa, for inviting me to speak here today, and I'd be glad to again to take some comments and questions in the few minutes that we have left. I hope this information was helpful for the participants.
It
Thank
was.
you.
Thank you, Dr. Lavie. Especially thank you for your enthusiasm. It takes um, when you were able to tell that story through all of the many studies you synthesized, your enthusiasm came right through, and that's really helpful for us to be able to understand the whole picture. So thank you for taking the time to go through that extensive review. It really helps us with our take-home messages for patients. Just before we go ahead and take a few questions, I just wanted to remind folks that if you are a nurse or a dietitian and would like to receive CE credits for attending, you will receive an evaluation through your email in the next day or so. We encourage you to fill out that evaluation. It helps us with program planning. It is required for nurses that you fill out the evaluation. For dietitians, we just strongly encourage it because we do use your feedback to plan these kinds of programs. So thank you. We will go ahead and take questions. I have Dr. Lavie. Why don't, if you wouldn't mind unsharing your screen, that would be great. Okay, great. I can see you better then. Okay, so in terms of patient counseling, you can see we have a number of questions here. I'm going to start with a question about those who follow a vegan diet. So this participant said, thank you for a great presentation. How would you address an idea that says that vegans or vegetarians are at a low risk for CVD, therefore improving EPA and DHA in vegans and vegetarians to promote their health outcomes is not needed, since vegans consistently have low EPA and DHA, typically below 4% of the omega-3 index. So how would you counsel somebody who's following a vegan?
So first of all, I think in general, I think vegans are going to be at a lower risk, but there's a big spectrum in the vegan population that of risk, because a vegan can still have cardiometabolic disease, can still have bad lipids, and so not every vegan is at the same low risk. I think in general, if you take all vegans compared to all non-vegans, they're probably at lower risk, but there's still going to be substantial cardiovascular disease among vegans because of things like lack of exercise, obesity, sugar and carbohydrates in the diet, and genetic factors. So there are still many other factors besides that. So for many vegans who are not at the very low risk, I think getting dietary sources of EPA, DHA would be beneficial. And obviously, then the key so some vegans would be able to take an omega-3 supplement. Some of them would not be able to do that because if certainly for religious reasons they may not be able to. But if someone's just doing vegan diet for health, or again, some of them would be able to take an omega-3 supplement. And of course, there are dietary sources of omega-3. I think the most common one is alpha-linoleic acid, but I mentioned you have to take so much of it to get the good amounts. But there are other non-fish sources of omega-3 that would be possible for increasing omega-3 intake if a person couldn't take the supplement.
Okay, yeah, that's really helpful. I think in general for us to realize that everyone has a different risk profile, and that has to be considered as part of all this advice. Any evidence that omega-3 has a positive effect on high-risk genetic lipoprotein A?
So I think talking about lipoprotein little a, I am personally using omega-3 routinely for patients with very high omega LP little a values. There are studies that show slight reductions in LP little a with omega-3, but I think that the reason that I'd be giving omega-3 to those patients is because they are at very high risk of clinical events, and omega-3 has been shown to reduce fatal heart attack, total heart attacks. The patients with LP little a have procoagulant effects. There are some mild anticoagulant effects of omega-3. There's effects on oxidation with LP little a, and so there are many potential benefits of omega-3 in patients with LP little a. Obviously, we need good therapies for LP little a, and hopefully those will be coming soon. But right now, the main therapy for people with very high LP little a is to try to improve the rest of their risk profile, get the LDLs under 70, maybe be on a baby aspirin per day. A lot of times I have them on antioxidant vitamins like vitamin C, but omega-3 and even in people with very high LP little a, that's when I'm actually trying to get the EPA DHA dosage to probably in the 1 to 1.5 gram per day range. Whereas for my general preventive recommendations, or for most of the patients with say a myocardial infarction or a stent, or have high risk lipids, most of the time I'm trying to get them to take supplements that have over 800 milligrams per day of combined EPA DHA. And of course, if someone's eating a little bit fish in the diet, I may lower the amount that I recommend in the supplement. For example, if someone's telling me they're eating salmon several times a week, or every now and then I've had a patient that told me they're eating sardines every single day for lunch, or tuna fish every single day for lunch. Obviously those patients may not need very much in the form of supplement if you try to figure out how much omega-3 they're getting on an average day from their regular diet.
Yeah. I think that that's really great advice in terms of helping us understand how to combine dietary intake with maybe the deficit that could be filled in through supplements. So thanks for walking us through that.
And I do think, Lisa, that the majority, I mean, again, maybe people can be encouraged to take some more dietary sources of omega-3, but I think right now, I do think most patients that we're seeing across the United States are not eating very much fish.
Okay, quick question. You talked about severe systemic heart failure and high dose omega-3s, and you talked about the improvement in cachexia and sarcopenia. Can you just tell us briefly, like, what the mechanism would be for that? Is that mostly just better
So,
oxidation
so the,
or?
the mechanism could be that the high dose omega-3 is having some potent anti-inflammatory effects.
Mhm.
Things like reducing tumor necrosis factor and reducing interleukin 1 levels, reducing other inflammatory proteins that are involved in advanced heart failure. There may also be direct effects of omega-3 on the heart muscle. So maybe actually, maybe actually improving in some aspect the heart contractility or efficiency. And then also it's a source of calories. And one of the big problems with very advanced heart failure is losing weight, cachexia, and so getting taking 8 grams per day, as we used in our study, is giving them some extra calories per day that may be also helping to maintain at least a little bit extra muscle mass. That generally when you lose weight, you certainly lose fat, but you also lose muscle, and that's not good for cardiovascular disease, and certainly not good for heart failure.
Yeah, thank you for bringing that out because as nutritionists, a lot of us in the audience, we do balance, nutritional needs with issues such as sarcopenia. And we're always trying to find that special sauce. What's the recommended duration of time to take high doses of omega-3 for someone who could benefit from it? And a related part of that question, is there like a titration or a tapering that's required if you begin to go off it? Does it have any kind of negative impact of just stopping?
So generally, I mean, you get the benefits from let's say if you're using high dose omega-3 for reducing cardiovascular events, you're going to start getting the benefits within a month or so, but you're going to lose the benefits with in a month or so after stopping the therapy. And if you use a high dose to treat triglycerides, you're going to get the lowering of triglycerides after a month or so. But once you stop them, the triglycerides are going to go back to the previous value, unless they did something else to dramatically lower their triglycerides in the meantime. So generally, the therapy is indefinite. So we don't usually, tell somebody to just use this therapy for a short period of time. If you do have to come off of it for any reason, and this would be an example. If a lot of times for surgeries, the anesthesiologist will tell people to stop their omega-3. Now, if they're on 3 and 4 grams per day of omega-3, that does have a slight effect to thin the blood. If they're on 800 milligram per day, it has no blood thinning effect of meaning it doesn't prolong the bleeding time. But still, the anesthesiologist will see it on the list, and so they will tell people to stop that omega-3. That's so generally you do not have to wean off of omega-3. Just you can cold turkey off of it and restart it, as soon as you're able to restart it again. But so it's not something that you have to, you don't get any kind of rebound effect by going off of it. You do lose the benefit though fairly quickly, when you do go off of it.
Okay. Have you had any cases of people having a side effect of muscle pain with omega-3? This participant said, she has personal experience with that.
Again, I can't say that no one's mentioned muscle ache, but there's certainly not. I do not know of a mechanism where that would be the case, and that has not been a problem in the randomized trials. You got to realize in an isolated patient, isolated patients will complain of a lot of things. And for example, in the statin trials, obviously everybody knows that there are some patients that get muscle aches on statin, but in the randomized trials, many patients who are on placebo were also reporting muscle aches. So people do have muscle aches are a pretty common thing, and so it's pretty hard to know if
What
they're
caused it?
from the omega-3. And obviously, if you had a bad muscle ache soon after starting omega-3, they went away after you stopped the omega-3 and then reoccurred after you restarted it, that would at least give support. Honestly, I think many people would say they would predict that the same thing would happen if the patient was restarted on placebo.
Mhm. Okay. All right. And just one more brief questions. Any issue with fish oils being used for those with pacemakers?
For those who what?
Pacemakers. Is
Oh,
that an
no,
issue?
no.
No.
No. So high doses of omega-3 can have slight slowing effects on the heart and an increased vagal tone, but it wouldn't have any effect on the pacemaker function. I guess you could say if it did slow the pulse enough, it would mean the pacemaker would be having to work more. Because the pacemaker is usually set at a certain heart rate, like a heart rate of 50 or 60. And so if their heart rate was 61, without the omega-3 and it dropped to 59 on the omega-3, then the pacemaker would be working more. But again, it doesn't have any effect on the pacemaker itself. It just would be affecting the natural heartbeat, which is why they would be having a pacemaker to begin with, to try to keep the slow heart rate away.
Sure. Okay. Well, thank you for telling a whale of a tale and doing it in such a way that we have lots of take-home messages that we can apply with our patients. So thank you for your generous time and wishing you, good success in the future. So
Okay, thank you, Lisa, for having me, and I hope this was helpful.
it was. And thank you to all of our attendees. We really appreciate you supporting our webinar series. Take care, everyone, and have a great day. Thanks again, Dr. Lavie.
Thank you.